Thanks for joining us. I'm Ian Boyne. Today we focus on health. Minister of Health, the Honorable Christopher Tufton, is our guest. We thank you for your company. Minister, great to have you on the show. Where are we with the Zika v H1N1 fight?
Okay, on both counts, I think we're doing well, and that is manifested in the number of cases that have been confirmed. We have not seen new cases over the last few weeks, so we're still at 6 as it relates to Zika v. And in case of H1N1, we're at 69 with, unfortunately, 7 deaths. So I think the threat has subsided. Having said that, we have to keep the public education going. We have to keep persons informed, motivated to take the necessary precaution. And I believe that is the most important part about the process going forward.
And the government is continuing its own thrust in terms of the things that it is doing in the communities and so on.
Yes, we continue to play our part in informing and encouraging, and where persons are found to be infected, in treating through the public health system. We have made some adjustments to the program. We are hammering the message of taking responsibility because the evidence suggests that 75% in the case of Zika v of mosquito, the breeding ground for mosquitoes is in the yards of persons. And so they have that critical responsibility. And
but hasn't the government sent teams in the yards?
Yes, we have teams out. I have been all over the place. I've been in about 4 or 5 parishes with the teams, but the work continues. But that is just to highlight the issue. The truth is we can't solve it totally. It's really going to be up to those persons to ensure that they do what they have to do. In addition to that, of course, we have a lab equipment that is able now to test for Zika v. Before now we had to go to Trinidad. And as a consequence, we can discover new cases a lot quicker and therefore treat with those cases once they are discovered. We are more informed, I think, with the medical fraternity, the private doctors, so that they can be on the lookout for the symptoms and therefore recommend for testing, which the lab is able to do at the university. In terms of H1N1, it's about hygiene. And we have been able to now protect through vaccination all the frontline health staff. We have imported adequate supplies. And the last report I got was that well over 90% of frontline health workers, the doctors, the nurses, who have to confront the symptoms and put themselves at risk, are now vaccinated. And that is very positive. In the past, we've had 25–30% of those frontline health workers not taking up the vaccine. This is different this time around. And in terms of the availability of Tamiflu, the recommended medication, pharmacies are now allowed to carry that, to stock it. And again, that is another line of defense to dealing with the problem. So I think we have made significant progress. It's no reason to be complacent. We have to continue the thrust because ultimately it's about a cultural change as a country to ensure that we focus on prevention rather than cure.
Minister, what new thinking, what new initiatives have you brought, are you thinking about for the health sector?
Well, first of all, I think it's very important for Jamaicans to recognize that to a large extent their personal state or state of health and wellness is up to them. Non-communicable diseases, the cancers, the diabetes and so on, are largely lifestyle related in terms of activity, physical activity, what you consume. And so one of the things we're going to be doing is really pushing on that public health information to change behavior. Having said that, we all know that the health sector is underfunded. 3.5% of GDP. In other jurisdictions, it's 7–8. In the US, it's 17. In the UK, it's probably 12–13. So government alone cannot provide the resources that are required, the infrastructure and so on. And we do have the private free healthcare policy, which we are embracing, we're endorsing. But we need to define that in the context of the limitation of resources and develop the public-private partnerships that are necessary. So one of the things we've been doing is coordinating a lot more the role of charities, the role of the private sector, both in terms of the distribution of drugs. So instead of going to the drug serve windows, we're going to look seriously at having private pharmacies play a role there, because that's a big part of the backlog and the waiting time. The diagnostic services, a lot of the waiting time in hospitals is as a result of persons waiting to access the CAT scan, the other types of diagnostic services. We're going to be expanding a public-private partnership approach to utilizing private capacity to serve certain types of cases where the public sector is unable to respond.
And people won't be paying the private sector prices?
No. We're going to be negotiating, and it's still going to fall under the ambit of the free healthcare up to a certain point, because we have to define what free healthcare is, and that's very important. The other very critical part of the partnership is going to be to enhance the relationship between the secondary and tertiary institutions, meaning the hospitals, and the primary healthcare, the clinics. Because a big part of the waiting time in hospitals is because people perceive the hospitals as being the one-stop. They can get everything. The clinics are closing at certain times, they're underfunded, lack personnel, and nobody goes to the clinics. But primary healthcare is absolutely fundamental to addressing a lot of the concerns and issues that arise. You don't need to go to the emergency room. So we're going to roll out a program starting with the larger hospitals where the excessive waiting takes place, to upgrade those clinics and to add some additional facilities, including longer opening hours, and start a process of sensitizing patients to move to the clinics for certain types of services rather than go to the secondary institutions. It's going to take a while in terms of getting that behavioral change, but we will start with upgrading those facilities, and we have about 6 hospitals that we're going to begin with over the next couple of months.
Yes. Minister of Health, the Honourable Christopher Tufton, talking about initiatives that he has for the critical health sector. He has more when we come back.
Don't make diseases spread. Wash your hands with soap and water instead. Wash them regular or use a hand sanitizer. Make sure the germs them dead. Touching your eyes or your mouth or your nose. Wash your hands before you do things like those. After you use the bathroom before preparing food, come on, wash your hand them clean.
Minister of Health, the Honourable Christopher Tufton, is our guest on Issues and Answers. Minister, the average person is concerned about the long waiting times at the hospitals. You mentioned the clinics. But are the clinics fitted to give the kinds of services that...
Not in a number of cases, frankly speaking. Again, resource limitations does prevent. There are different types of clinics, the type A, B, C, whatever. The different, depending on how they are graded, there are certain expectations. We're going to have to ensure that those expectations are met, particularly in some of the critical strategic areas, recognizing the resource limitations. We have 320 clinics throughout the country. Of course, you have the parishes with the main hospitals, where the waiting time is the challenge. I can give you the top 6 or 7: Spanish Town, KPH, Bustamante, Maypen, Mandeville, for example. There are clinics on the compound in some instances of these hospitals or across the road. So if we can recalibrate what is offered in these clinics by looking at some of the causes of the clogging of the hospital emergency rooms. Take asthma, for example. I am told that on a given day, you could have 20, 30 persons going to the emergency for asthma. Now, it's not that expensive to create a scenario at the level of the clinics with extended hours to have the facilities to treat with that particular ailment. And what you'd be actually doing is removing that fairly large number of persons from the emergency rooms to the clinics for treatment, and therefore free up that system to deal with some of the more pressing stuff that the clinics can't deal with. It is a challenge. It's a mindset issue also. People feel that they get better attention at the hospitals because it's a one-stop, the doctors are there and so on. But I think it's worth working on, because for the system to do well, you're going to have that synergy between primary and healthcare and the second and tertiary healthcare.
Minister, cancer care, the expensiveness of cancer care. Any new thinking in that area?
Well, there are, again, it depends on the particular areas of cancer. There are some that are more prevalent than others. It starts again with lifestyle to a large extent, and therefore any issue to improve healthy living will also reduce the risk of cancers or certain types of cancers. Assuming, however, that the worst takes place.
That's right.
The issue now becomes what is the infrastructure that is in place. And there are some centers of excellence that are on the drawing board. One such is I'm hoping to realize within the next year or two, and that is to construct a physical structure on the St. Joseph's compound, which will house the administrative activities of the ministry. Right now we're in 6 locations in New Kingston. We're paying almost $400 million a year for lease payments. It just doesn't make sense. So we have the facilities, we can build a facility, we can also establish at that facility a center of excellence to deal with things like cancer, not just for Jamaica but also for the region. I took that to cabinet recently and that has been approved, one of my first submissions. So the idea now is to pull the team together to develop that concept and to move it forward under a private-public partnership, which will now allow for specialist care, even while it allows for more efficient administration of the healthcare system.
The availability of drugs is another major issue. People go to the hospital, they have access, but they can't fill the prescriptions.
Well, there are 10 areas that the public health system supply drugs to deal with as a public good. The procurement through to inventory management and distribution, the value chain of that process requires some assessment. The National Health Fund currently does the procurement, and the ministry does have inventory management functions currently. And in some instances we use some of the private drug companies to help with that. And then of course it flows through the drug serve windows, which are limited in numbers, and from time to time if you pass there you see these long lines.
Yes.
In the case of drug for the elderly and drugs for AIDS, there are limited availability in the private sector pharmacies. I would like to see an expansion of that program, both in terms of how we procure to get bulk purchases and get better prices, but also how we store and distribute to the final consumer. If we have patients who can go to their pharmacy in the town square to access this program, it is going to clear up the backlog, reduce the waiting time. What we have to do now is negotiate an arrangement, a structure, which we have done under the Drug for Elderly with these private pharmacies. And I have asked the new chairman of the NHF, Mr. Christopher Zaka, to establish a subcommittee of the board, and he has a really good board, and himself, of course, very competent, to look at how we can establish that public-private partnership to make drugs more available and more accessible to those who we serve.
And you really look at the regional health authorities, the whole system of the governance of the health system.
The regional health authorities, of course, was intended when it was established to establish a more semi-autonomous management of the system in these 4 regions. In some instances, to my mind, it has worked. In a number of instances, I think we can do a lot better. I think there needs to be a lot more coordination between the regions, particularly as it relates to things like sharing of expertise, and so we're looking at things like telemedicine, because you don't have you have the experts at UWI, you don't have them at Savlamar, and the truth is people administer healthcare between India and America all the time through technology, so it's not difficult to do, and we do have the technology to do it. Procurement of diagnostics equipment and other types of equipment, which is influenced a lot by the regional authorities, but not necessarily coordinated sufficiently between regions to get the benefits of understanding and learning as to what is most appropriate. So there is a proposal for a 10-year strategic development plan, which I inherited. I came and I saw the thrust, and I'm very, very supportive of it. And I'm going to be meeting with the team to look at that strategic plan or the development of it in a way that also examines and evaluates the effectiveness of the regional structure, and where there may be need for an adjustment of that, I have no difficulty in making that adjustment, but I'd prefer to get the work done first.
Yes. And at the end of your tenure, Minister, what overarchingly would you want to be assessed by?
Well, I think the concept of universal access is a much more important concept than the cliche or terminology of free healthcare. And I think we have to spend some time explaining that to people. For me, it is about not depriving or denying anyone who needs it and cannot afford it. To me, it's almost a human right. And so I think we have to define free healthcare in that way.
Universal access.
And therefore, in my own legacy would be that persons have access and quality access and timely access, because a big part of that is waiting. Absolutely. I mean, and another area of it that I think is important, Ian, and that is how we administer healthcare to people. I'm a believer in compassionate care. There is an element to healthcare administration in Jamaica that requires a demonstration of compassion. It's part of the healing process. Yes. When people are recuperating, they must feel as if they're in an environment where they get support. And I'm actually working with the technocrats to develop a program that is non-medical in terms of the science of medicine and more the psychology of medicine and how you get people to feel as if they are welcome when they come into these public institutions. And frankly, get volunteers. We want to we want to establish a volunteerism policy to get volunteers in the hospital, whether you're combing a lady's hair, reading the newspaper to her, as part of the recuperative process. And I would like a legacy that where the perception around the administration of healthcare in Jamaica is adjusted, not just in terms of the dollars and cents and the infrastructure, but in how people view their public institutions, and in this case, the hospitals and the clinics.
Thank you very much, Minister, and I'd love to be a part of that volunteers program. I encourage everyone to be actively a part of this volunteer program. Very interesting insights from the new Minister of Health, the Honorable Christopher Tufton. Next week, I'll be back. Until then, Ian Bourne wishing you a pleasant day.